Hi, I'm Liz. I'm going to be doing the scapulothoracic joint today. This is Genevieve. She's going to be helping me out. I'm going to be doing range of motion, manual muscle testing, and a length test for her. We're going to start off with some range of motion. We're going to do range of motion for shoulder flexion. This is combined with scapular depression. So what we're going to do is have the axis of the goniometer lined up with the midpoint of the humeral head, and the stationary arm is going to be parallel with her trunk, and the movable arm is going to be midline with her humerus, lined up with the lateral epicondyle. So this is going to be a passive range of motion. So I'm going to push her up, line up the goniometer, and push her into full shoulder flexion. And she's at about 170 degrees. Normal is about 180 degrees. At this joint, the first 120 degrees is going to be mainly the GH joint. And then the next 120 to 180 is when you have the scapular movement. If you have problems with the scapula at this point, it can be part of your rhomboids, your lower traps, or even your latissimus dorsi. So what we're going to have her do next is we're going to test her shoulder abduction, which is going to be scapular upward rotation. If you could face that direction, so you can have your back. I'm going to line up the axis with the center of the GH joint on the back side, and then the stationary arm is going to be again lined up with the trunk, and the movable arm is going to be again lined up with the midpoint or the midline of the humerus to the lateral epicondyle. So I'm going to push her up, and then normal for this is also 180 degrees, and we're going to push her until I feel a firm endpoint. At this point, pushing her into it, she has about 175 degrees of shoulder abduction. And once again, from 120 degrees to 180 degrees is when you have that scapular rotation, especially for the upward rotation. And if you don't have full range of motion, it could be problems with your lower traps or serratus anterior. Hi, we're back again. Now we're going to do some manual muscle testing. We already have my patient in prone, and that's where the first test is going to be for the rhomboids. The rhomboids are going to originate on the thoracic vertebrae of T2 to through T5, and they're going to insert onto the medial border of the scapula, and they help in adduction and downward rotation of the scapula. For this test, I'm going to have my patient bring her arm out to 90 degrees, and she's going to have her thumb pointed down, which puts the arm into internal rotation, which is going to be which is the normal position. And I'm going to push her against the normal adducted into abduction, so it pulls apart, and we'll see how strong that is. I'm going to push down, and I'm going to count out for a 3 for a muscle grade is going to be if she can hold it against gravity, which she is doing. I'm going to start applying slight pressure to her in an increased motion, and then when she finally breaks through, that's when we know what the grade is. So as I push down, I'm going to give her 3, 3 plus, 4 minus, 4, 4 plus. Alright, I give her about a 4 plus. I could have probably given her a little more pressure, which would have been a 5. So that is the rhomboid test. The next test we're going to do is the lower traps. The lower traps originate on T6 through T12, and they originate on T6 through T12, and they insert into the spine of the scapula. They help to depress the scapula and to do upward rotation. So for this test, I'm going to have her in line with the lower traps, and I'm also going to have her slide off to the side of the table a little bit, so it keeps her arm up and away, so she can do that with her muscles. So I'm going to have her face her palm towards herself, and I'm going to do the same thing and push down, and I give her probably about a 4 on this one. Because again, a 3 would be against gravity, and then a 4 would be moderate pressure, and then a 5 would be against heavy resistance. So that is the lower traps. My next manual muscle testing is going to be the serratus anterior. So I'm going to have you flip over on your back, face supine. And for all these muscle tests, there's going to be no stabilization by the therapist, only the pressure. Okay, for serratus anterior, it originates on the upper 8 or 9 ribs and inserts into the medial border of the scapula on the costal side. So it helps to really stabilize the scapula in place. It also helps to abduct the scapula. So for this test, I'm going to have her again at 90 degrees of flexion, and she's going to push up towards the ceiling against gravity. To get into this position is going to be a muscle rate of 3, and then I'm going to apply pressure, so 3 plus 4, 4 plus 5. So she can really put a lot of pressure into that. So I know she's about a 5 out of 5. And those are some muscle testing for the stabilizers and the movement for the muscles of the scapula. Okay, so next we have the postural analysis for the scapula. In this, we can see whether or not the scapula are elevated, depressed, upperly or downwardly rotated, or abducted or adducted, or even if they have slight winging. In this patient, it seems that she has slight winging of the vertebrae, which is an anterior tilt. It's kind of hard to see in the video itself, but you can see how her inferior angle pops out against the skin. And this could be caused by many reasons, but one might be tight pec minors, which causes that, and we can test that in the pec minor length test. Okay, so next we have muscle length testing. What we're going to do is we're going to test the pec minor length. And this test is important because it can show if you have tight pecs, then you can have rounded shoulders, and you can also have winging of the scapula or an anterior tilt. So to do this test, we're going to have the patient lie supine on a hard surface, and we're going to see how far her shoulders come off the table. Since she is slightly rounded in the shoulders, we can see that that might be tightness of the pecs. It could also be tightness in the biceps or of the coracobrachialis. So what we're going to do is put those other two muscles on slack and see which one it could be. So first we're going to do the biceps, and what we're going to do is put her arm into external rotation and flexion, and then we're going to see if her shoulder goes down at all with that. And since it didn't, we would say that it's not biceps as being tight. It could also have been the coracobrachialis. So to put the coracobrachialis on slack, we're going to put her elbow into extension in this position. And it slightly came down, so that might be an indication of coracobrachialis tightness. But if it didn't, then what we're going to do is then we would know that that would be pec minor tightness in this patient.